But today we're very excited to welcome Kimberly Williams, the executive director. Let me get this right. I read Medicaid, but there's a longer name to it, Kimberly.
Well, officially it's the Bureau of Health Services Financing, but we just call it Medicaid.
That's it. And Medicaid's what stuck in my mind. But Kimberly has graciously accepted our offer to present today and talk to you about Medicaid, which we did talk about at the summit, and it's been on Ellevate's radar actually since our policy positions last year. We know that there is a plan that is due in November for Medicaid reimbursement, increasing Medicaid reimbursement rates. And we are just excited to hear from Kimberly about what's going on at the Department of Health and Medicaid. So I think with that, I will hand it over to you, Kimberly.
Thank y'all very much. I thank y'all for letting me come speak today. I appreciate it. I'm Kim Sullivan. I am the Medicaid Executive Director. I've been in this role for a little over a year now, but prior to being Medicaid Director, I was an attorney in LDH legal, handling Medicaid and health standards legal matters for like the last 19 years. So that's my background. I'm going to start with a brief overview of Medicaid and then talk about some of our priorities that we have with the new administration who came in. So right now we have about 1.6 million people enrolled in Louisiana Medicaid. It's about 35% of the state's population. However, we do cover about 60% of all births in Louisiana. For comparison purposes, the states that border Louisiana have about 25% of their state's populations covered by Medicaid. This appears to be the case in bordering states that are expansion and non-expansion states. As you know, Louisiana is an expansion state, and our uninsured rate remains below the national average. According to the Louisiana Health Insurance Survey, approximately 8% of adults in Louisiana are uninsured, and about 3.5% of children are uninsured. From the Medicaid perspective, of course, we want any individual who is eligible for Medicaid to be covered by Medicaid. For Medicaid this year, we have several initiatives that are priorities for our new administration. In regards to reimbursement rates, according to Kaiser, Medicaid reimbursement in Louisiana is similar to Texas and Florida, but it is less than Mississippi, Arkansas, and Alabama. Senate Bill 190, which is Act 306 of the 24 legislative session, asks LDH to review reimbursement rates for physicians. We have an independent third party, Milliman, who is our actuary for managed care. They are helping us prepare that report to the legislature. That report is due November the 1st. So that report is going to address how LDH will get to 100% of the Medicare rate for physician reimbursement over a 2-year period. So that report's going to be coming out really soon, and that will detail and lay out LDH's plan on how to get to that 100% of Medicare to reimburse our physicians. And also, since the mid-levels, such as the nurse practitioners, since they are paid at a percentage of physician rates, they will also see a rate increase if we increase the physician rate as well. So you will probably see them included in this report as well. Let's see. So the big thing about that legislation is going to be how do we fund it? It's going to be a lot of money, of course, to get all the physicians up to 100% of Medicare. So the big thing that will be up to the legislature is how do we fund that rate increase for our physicians in the state once they get that report. Our other priorities that we have are we're going to be releasing a new RFP for our MCO contracts probably in May of 25. So you will see an RFP come out for new managed care contracts. We're already, of course, starting to work on that. We also are focused on our state health improvement plan. Our agency leadership developed this plan, and we have some major focus areas that the department wants to work on. These focus areas are behavioral health, chronic disease, and maternal and child health. So for behavioral health, we want to ensure people have access to behavioral health services. We want to address adverse childhood experiences, and we want to reduce deaths from drug misuse. In regards to chronic disease, we want to increase access to care. We want to reduce diabetes. We want to promote healthy weight, improve cardiovascular health outcomes, and reduce cancer rates and improve screenings. For maternal and child health, we want to improve our birth outcomes, improve child and adolescent health, improve maternal health. And also, we recently applied for the Transforming Maternal Health Grant from CMS in September. CMS plans to announce the states that they will award those grants to in January. So we did apply for that. Hopefully we will get that grant, and that will we will use that to address our maternal and child health outcomes that we need to improve upon. We're also planning to apply for the cell and gene therapy model grant. And our focus here is the new gene therapy treatments that are available for sickle cell disease. So that is CMS is trying to do that at the national level to see where they could get better pricing if they do it at a national level, because these drugs are very, very expensive. So we will be participating in that. And I think we had to send in our intent letter to let CMS know we'll be participating in that. But that should be getting kicked off too, I think, at the beginning of next year. We also recently submitted our application to CMS for an 1115 waiver for the pre-release individuals. So these are individuals in our state prison facilities and our reentry facilities. And we're going to start off with a small subset of parish jails that will be in this 1115 waiver. Once approved, the waiver will allow us to provide certain covered services during the 90-day pre-release period. With the waiver, we plan to cover case management, Medicaid assisted treatment, and a 30-day supply of prescription medications upon release. That's just some of the services. We have a few more services that are detailed in our waiver application, and that should be on LDH's website if anybody's interested in going to look at the actual waiver application. We do have to have, of course, full approval from CMS before we can implement the waiver. And we believe this takes a little while. Typically, it might take CMS up to a year to approve these types of waivers. So this is going to unfortunately be a long process, not a short process. But we do anticipate getting approval. CMS has approved this waiver in many other states, so we don't think that's going to be an issue. It's just how fast will CMS actually approve and how fast can we start implementing. We also have to move on a quicker timeline to implement. There's a new required targeted case management service for youth who are incarcerated that we have to implement. This case management is going to occur 30 days prior to release, so that case manager can help set up necessary screenings, medical appointments that the child would need before they're released from any type of incarcerated setting. So that we are working with OJJ, the Department of Corrections. And we also have to work with the parish jails as well to get that implemented across the state. So we have to have a plan to CMS in January on how we're going to implement that, and our state plan amendment for that has to be has to be into CMS by the end of March of 25. Let's see. A couple of other things we're doing with our member experience. We now are able to text our Medicaid members. So we text message them in regards to their renewals and when those are due, or when we need them to submit documentation that we may need in order for them to keep their coverage. We also have a chat bot that we added to our website. So this gives members 24/7 access where they can ask questions in natural language, and it'll pull up the answer like in a matter of a few seconds. We've gotten really good feedback from people on the chat bot. So we are happy and excited that got implemented. We're also currently working on adjusting our staffing so we can expand our customer service hours for eligibility. So the secretary would like to do that, like probably a little earlier in the morning, and then a little bit later in the evening to help folks who actually, who go to work every day. Because I think our normal hours are 8:30 to 4:30 or 8 to 4:30. So we're looking at expanding our hours so we can let people have the ability to call, when they get off of work in the evenings. We also have, I mean, Medicaid's got a ton of other projects and priorities we do every day. But that's just the big highlights of the things we're working on, for this coming year. But I am happy to answer, any questions you guys may have.
First of all, that was a lot of information, so I'm glad we taped it. But I think Kelly Williams actually had, oh, go ahead, Julie.
Well, I just, because it's one of our priorities, from a policy perspective, we issue policy priorities, and one of our policy priorities is to get the Medicaid reimbursement rates up to the Medicare reimbursement rates. And, I know the answer to this, but I just want you to share why that matters so much.
Yeah, I mean, we are hearing from our primary care doctors, especially and our pediatricians, that it's just hard with the, to see enough Medicaid folks with the rate that we pay. And also they're having issues and troubles accessing specialists. So when they go to their primary care doctor, some of them have told the secretary the reason they don't want to take more Medicaid patients is because they don't have a specialist they can refer to if they need to for that Medicaid patient. So we're hoping if we can increase it to Medicare, we all know these physicians have a lot of Medicare folks in their panels. So we're hoping if we can get it up to Medicare that these, specialists and our primary care docs will be willing to see more Medicaid patients.
Yeah, exactly. And I had one or other question too, but you mentioned sickle cell.
Yes.
And sickle cell is one of the illnesses that has just become, where they've got this like precision medicine approach to solving sickle cell. Totally exciting. That's a lot of what you've seen, a lot of that in the world of cancer. And that's how it really came to my attention. And I've been very much having on my mind about moving forward with the sickle cell and how do we get more insurers to cover it. Now, do you know if private insurers are covering that at this point? Or
I
is it still,
Yeah,
yeah,
I don't know. Those medications I know are like at least $1 million or $2 million a piece. Those new medications that just came out, and it's a very rigorous treatment. It's not something we think a lot of people will actually take up or take interest in, because it's a very difficult treatment for people to undergo. But I am not sure if private insurance is covering those new sickle cell medications.
yeah, because it's basically they're custom making a medicine
Correct.
to each patient. So that's why it's so difficult. But some people live in excruciating pain their whole lives because of sickle cell. So, any shot at being able to get healed would be amazing for so many out there. But yeah, so I'll go ahead and switch over because I know that Kelly Williams and Julie Harris did also have questions, and I will yield to Yvonne for a bit.
Oh, I was just going to say, Kelly. Yeah, I think Kelly had her hand up first.
Yeah, sorry. And I appreciate it. I'm about to get on a plane, so I apologize. I'm in the airport. So it may be a little bit of background noise. But thank y'all. Thank you for the information. I think that's great. And I appreciate y'all sharing exactly what all we're doing around Medicaid, because I think that's super helpful. Two things. Well, one, Julie, I know that the Health Disparities Task Force is working on the sickle cell conversation. And so if anybody has more interest, I know they've done a lot of research around that. And that may be a place to go to ask some of that conversation. And it's Karen Weibel. On the other note that I was just going to share, I do represent the Louisiana Association of Nurse Practitioners. And Kimberly, I appreciate you all looking and including them in what y'all are doing from the reimbursement rates, because I do think that the nurse practitioners service a lot of Medicaid patients in the state. I do have some differing data around whether or not when you increase the physician fee schedule, if it would automatically increase nurse practitioners, and would like to share some of that information with you between now and before y'all maybe submit that report, because I don't have the details, but I can get them, and somebody has done some extensive research on it.
Sure, that would be great.
So I'll just get your email from Julie and email you. Maybe we could set up a time and I can get the people who know what they're talking about on the phone.
Sure, absolutely.
Quite a few aides
Awesome.
still.
Thank y'all.
I've ordered all the aides
Thank
for
you.
New Orleans. Come on
Thanks,
in.
Kelly. Julie
I wanna-
Harris.
Yeah, I want to underline what Kelly said about Karen Weibel, who does work with the rural health collaborative as well, and work on just how important that access to sickle cell care because of the cost. It's just outrageous that it's not covered already. So many people are suffering from it, and when there is a solution. Something similar, hepatitis C. I was diagnosed with hepatitis C. I had a blood transfusion. I was not a drug user, but I had a blood transfusion many, many years ago, and I had inactive hepatitis C that they discovered, and it was easy. I mean, it got paid for by I got treatment, and it was gone, and my threat to my liver and my threat to my life was gone. But many people don't get that, and particularly incarcerated under Dr. Gee, I remember there was an effort to get some sort of deal with the drug manufacturer for those who are incarcerated to also have
Right.
access, because there's a huge, is that still ongoing? I have triple
It
question,
is.
but is that still
Yeah,
ongoing?
we just renewed, that agreement with the manufacturer. So yes, that is still in place.
Good. Well, that's a great thing that you're continuing it. And then have you seen less churn in those eligible, because you are able to text, and because of the expansion of the 24-hour access to an answer on a helpline? Or is it too early to tell that there's been less churn in the in being eligible and ineligible for Medicaid?
Well, we're done with our unwind. So we went through that whole process of doing everyone's renewals, and that process is over. We're not, I mean, the churn is kind of pretty much probably almost done by now. We only had, the last time I checked, we had about 240,000 folks who had lost their Medicaid during that unwind period and who remained disenrolled. So those people, we just started about a month ago, we started a text campaign for those people to tell them, if you are, if you think you're still eligible for Medicaid, please go to your nearest application center. We did get some people to respond and reapply and come back on the rolls. The secretary has access to do that campaign, texting these folks for a couple of more months to see if we can get some more people back on the rolls. Because we don't want anyone to lose their Medicaid if they're eligible. And texting seems to be the best way, to be honest, to get people's attention. And we can verify that they got the text. That texting has been a good, actually a good new tool that we've been using since Unwind started.
Wonderful. I'd love to see what the long-term, and the last quick question is care while incarcerated. Obviously there are these good efforts going on to get people just before release and after with the youth. And of course, that may not be under the Department of Health. I guess it's under corrections, right? Care while incarcerated.
The waiver we're applying for will let Medicaid pay for certain services up to 90 days before they're released. So we will be able to pay for some Medicaid services. It's going to be substance use treatment, pharmacy. I think there's going to be some lab services. I'm trying to think what else. Case management. So Medicaid will pay for those folks that are Medicaid eligible 90 days before they're released. Now, while they're there before those 90 days, that is the Department of Corrections.
All right. So I think the next person who had a question was Caroline Meehan.
Mm-hmm.
Hi. Hey, Kim. Good to see you.
Caroline.
So my question is about budget. So I know, we're going into some what look to be pretty tough budget years, and those conversations have already started happening. And I know, when the state is in budget trouble, it is typically higher ed and healthcare that take the hit, and within healthcare, it's really Medicaid and optional Medicaid. And so I was just wondering if you could talk a little bit about that and how your team is sort of thinking about that, trying to plan for that. And if there's anything Ellevate could do to sort of support you and advocate for continuing really important medical services.
Yeah, well, the secretary and undersecretary went to House Appropriations a couple months ago to explain if we had to make budget cuts, what would be cut. So they put that out in their presentation. I mean, I can send that to y'all if y'all would like to see that hack presentation. But they did go through what Medicaid would have to cut if we got, I forgot how much the budget cut was. But yeah, of course, we don't want to cut anything, if we don't have to. But yeah, we've already gone through that exercise. So we have that preliminarily. I mean, until though we know how much we may have to cut, I mean, then we can really get down into the weeds, I guess. But we do have that hack presentation that would explain and lays out exactly, what Medicaid would have to cut, what's optional services, what are mandatory services. Because yeah, mandatory services we can't touch. So it really, when you're talking that large of a budget cut, you do have to go into, unfortunately, optional services.
Yeah,
that would be great if we, sorry. It would be great if you could send that to.
Yeah, I can do that.
Distribute it to the committee.
And I'll add, just because I mean, a lot of what was laid out was cutting programs for people with disabilities and people who are elderly, which of course is the world that I live in. So,
yes.
So just, I think, and it's important to know, like, optional Medicaid doesn't mean they're not important or they're not critical. That's just the designation from the federal government, right? So
absolutely, yes, that is the federal government's definition of what's mandatory and what's optional. But yeah, I mean, for example, pharmacy is optional. I mean, we could not go without pharmacy services for Medicaid folks. I mean, but that is technically something you don't have to have as a Medicaid program.
Thanks, Kim.
That would be pretty difficult to.
Yes, that would be very difficult.
Any pharmaceuticals. So, all right. So next we had Jeannie Donovan.
Hey, Kim.
Hey, Jeannie.
I had a question about the transforming maternal health model. I was wondering if you'd be able to share in sort of high level what you all included in the application in terms of approaches to improving maternal health, and if not awarded, as I know, I'm sure it'll be pretty competitive among the states. If not awarded, is there sort of a plan B for trying to incorporate some of those strategies into the LDH work and Medicaid work going forward?
Oh gosh, Jeannie, you made me rack my brain. I would rather give you. Let me make. I don't remember exactly what all is in there. I'm pretty sure that we put the home monitoring in there. I think, if I remember right. I'd be lying if I told you I know what it is off the top of my head. I can give y'all the link. I think are the applications public? I can't remember.
They may be at some point. I don't think they're posted yet. But if there's something you can share, I'm happy
to. I can get that for you though. Okay. Yeah, I can get like what we put in there. I'll get that for y'all and send it out. I hate to speak when I'm not 100% sure, but yeah, I can get that for y'all so you know what we put as the priorities in there.
Got it. Thank you.
Oh, you're very welcome.
Yeah, I'll collect everything and then I can distribute it to the committee. But we also had Kathy I want to say Kleber, but it's probably Kleber, right?
It's Kleber. It's Kleber.
Okay.
Okay. I have two sort of groups of questions, Kim. The first has to do with the MCOs. I know you talked about y'all putting out a new RFP. Has there been any talk of limiting the MCOs? And sort of a question that's similar to that is, have y'all done anything in terms of streamlining some of those processes like credentialing and other things for those providers that constantly complain about them? I know you get those complaints as well. So those are my two MCO questions. Are y'all considering limiting the number from 6 to a lower number? And have y'all looked at what are y'all doing in terms of helping with some of those streamlining?
Yes, the secretary has made known that they do want to reduce the number of MCOs that we have. I do not know what that new number would be, but I think there is the intention to reduce the number of MCOs that we have. In regards to provider enrollment and credentialing, yes, we are moving forward with a single entity. We actually have vendors coming in next week for demos, and we will be picking a new vendor next week for our single credentialing and enrollment. We're going to use the NASPO process for that. And with the new legislation that got passed this past session, that using the NASPO process will eliminate a protest. So we should be able to implement this, quickly without a protest. So I'm happy about that. So this is going to allow the providers to go to this one entity to enroll in Medicaid and credential with all of the MCOs at one time. So they don't have to go do it with each managed care plan. So it should make the providers, they should be very happy about going to one entity and not having to go to each MCO to credential. We're hoping to get that done in 18 to 24 months. But we are starting on that actually next week.
Excited about that you're using that process too, which I know is a lot quicker. And I mean,
Yes.
that's one of the whole problems we've always had with those trying to do this, since we've been trying to do that probably for 10 years, is
Yes.
that, to get protests. But I am happy to hear y'all are moving on it again. So my second group of questions has to do with behavioral health.
Mhm.
And how important crisis management and crisis services are to me, especially my work with Bridge Center. Do y'all have any movement in terms of, I know they're still kind of struggling statewide. I work both with Bridge Center and START in Homa, and know that they just can't seem to get the services in the right way with the right payment. Do you know anything about that? Any movement on that?
I am not that aware. I'd
Okay.
have to ask Karen Stubbs, to
Okay.
be honest. I know, I think, for the mobile crisis that rolled out, I know there haven't been, it hasn't been a big uptake on that. I think Karen, is trying to get, where you call just one entity and they can distribute out for mobile crisis instead of calling a bunch of different phone numbers. So I think Karen is working on that, but I'd have to defer to Karen, Kathy. I don't know what they're doing in regards to like the Bridge Center type providers.
Yeah, that's fine. And we're probably going to get with Karen too about some of this other stuff. So and I guess my next question has to do with the community. I'm never going to get the right initials. That new behavioral health concept of clinics that some providers have gotten grants for. And I
Oh,
know
yes.
that, yes,
I think Karen, I
CBHCD.
think that will be in our budget request for next year.
Okay,
I believe.
okay, that's good.
Yes.
Well, that's helpful to us because we can help support that. We know y'all are going to have it in there. So, okay, that was my two big areas.
Thanks, Kathy.
Yeah, one of the things I learned recently that was the most shocking to me was that mental health services in Louisiana are reimbursed at $22 an hour. And in Mississippi, they're reimbursed at $137.50. Wow. I think, it's no wonder we have the kind of problems we have, huh?
Yeah, we do. Our reimbursement is actually a little less than Mississippi, Arkansas, and Alabama, actually. Yeah.
Yeah.
Is it not less than Texas?
No, we're kind of on par, like with Texas and Florida, at least for the physicians I know. I'm not sure about behavioral health, but I know some of our southern states do pay better than we do.
Yeah, and I'll add to that. Last session there was a big push. It was a budget push. It wasn't part of any individual piece of legislation, but there was a budget push to increase the rates for addiction treatment and for mental health providers. And I believe it went back and forth as the budget crossed chambers. Mental health was in, mental health was out, and I think in the end it was only the addiction treatment providers that ended up getting that increase. I think it was a $10 million allocation.
Yes, and I think Jeannie, I think that goes into place soon.
Okay.
That it technically, I mean, it's just a temporary rate increase because we only got it like for one budget year, I believe.
Oh, okay. So I think traditionally the addiction treatment providers have sort of led that push. And so when push comes to shove, the mental health services sort of that have fallen out historically. And so I think with more advocacy on the mental health side, there could be a push for increased rates on that, because I agree with you, Julie. It's a huge problem. And we really need,
Yeah, I think it's been many years since we've increased our behavioral health rates.
Okay, I had one more question if that's okay. Y'all okay with that?
Yes, of course.
Okay. My favorite subject, Kim, long-term care.
Yes.
Y'all have any changes that we could look forward to, or any differences in terms of, I know y'all have looked at some licensing changes, after the Bob Dean stuff with the nursing homes, but what else is on the horizon for long-term care, if anything? Can you tell me?
I'm not aware of any new changes or pushes for long-term care, Kathy. Not I don't know of any new services coming. Nursing homes are going to be, the same. Their reimbursement rates are, set out in statute for the nursing facilities. But no, the only thing is that for nursing home reimbursement, we are changing from the RUGS based to a different payment methodology, and that's because CMS is requiring us to do that. I believe that goes into place next year. So there will be a different way to calculate the reimbursement rates that nursing homes get. It will not be based on RUGS anymore. And we're finalizing that. And I think that goes into effect sometime next year. But no, I am not aware of any significant changes in long-term care.
What about weren't there some changes in health standards in terms of, again, disaster response and those things?
Yeah, there was a bunch of changes for emergency preparedness for nursing homes. Now LDH has to actually approve those emergency preparedness plans that the nursing homes submit to health standards. Prior to the Bob Dean and that hurricane, we didn't have to approve them, but now we have to. So yeah, Health Standards has a new team of folks that actually look at all of those plans and actually approve each individual plan. And they go out, if you're not going to shelter like at another nursing facility, and let's say you have like a building you might want to use, they actually have to go out and inspect those buildings before they'll approve letting a nursing home use that as an evacuation site. So yeah, they did make changes to the nursing home emergency preparedness, pretty significant changes. And those are currently in place.
And y'all do have the increased waivers for those, wasn't it 750 home
for the OAS
community choice for OAS.
Yes, for the OAS waiver. Yeah, there were
that's
750 new slots, I believe.
Right. Yes, and that's moving forward. There's no changes with that. Okay.
Correct.
That's helpful. Thank you.
You're welcome.
Kim, do you want to know just the rate methodology work in OAS as well?
Oh yeah, so we are studying the ICF and the HCBS rates. We have 2 contractors that are doing that. That is in process. So we're excited about that. We haven't done that in quite a very long time, if ever. I don't think we've done it ever for home and community based. Never. So we're finally, doing some rate studies. So we're doing a rate study, home and community based providers and the ICF providers as well.
All right. I see that Shelley Dupre has a question.
Yeah, thank you. Kimberly, I'm asking this because I'm probably going to be out of town for the next Council on Medicaid Pharmacy Reimbursement meeting. But for the improving the diabetes rates that you have as one of the priorities for the department, is there, and I'm sure Randall Johnson has spoken with you guys about this already, but is there a look at having the pharmacist being able to be reimbursed, doing point of care testing for diabetes and being reimbursed on par with physicians if that happens?
I am not aware of that at all. I have not spoken to Randall about having the pharmacist test for diabetes. I was not aware of that.
There is an ability for them to be able to do that. I know that I don't think they can do that here, but I know we've discussed that with LDH before.
Okay.
But some of the problem has been the reimbursement on that.
Okay.
So it's probably something I'll put in my notes. Maybe we can have that discussion later too.
I was not aware that was even an option.
Okay. All right. Thank you.
Thank you.
Okay.
Right. Julie Harris seems like she's got one more.
I don't want to take away from somebody who hasn't spoken yet. All these wonderful things you are working on, and do you have the personnel, the capacity to keep the personnel or get the personnel, whether it's around increased requirements for standards or increase this or, working with formerly incarcerated, all of the work that you do requires people. And you're getting more work, it sounds like, and you're trying to do the work better. And so that means more people. So what in your budget, and I didn't see, and we'll see what you send, you're going to have higher requirements, not even just a standstill budget. It sounds like you need a lot more to do effectively what you're trying to do.
I mean, I think we have adequate staff to handle everything now. I would not want to see, of course, staff being cut if we have some kind of budget cuts. I mean, I don't think we could do with less staff. And I don't think the intent was to cut staff at all. I don't think we would have to probably do that. But I think we do have adequate staff to handle these things. And especially if we do actually decrease the number of MCOs we have. I mean, because it's a large administrative burden to, administer and handle 6 MCOs, compared to a reduced number. But no, I think we have enough staff to handle everything. We also have the ability to hire contract staff. We have a contract with the University of New Orleans. And we can get staff through them if we need to kind of fill in some gaps if we have some gaps anywhere. So we do have at least Medicaid. I can't speak for the rest of LDH, but Medicaid has that contract with the University of New Orleans where we do have them and use that staffing contract quite a bit to, fill in some, some gaps where we might have some. But I think we're adequately staffed to handle everything.
I guess I was thinking the larger department. The department at large, and that's more for the committee to think about is, we go into this session with what our policy priorities are regarding changes to the budget. Thanks.
All right, guys. I was looking to see if I saw any other questions that were out there, but I don't right now. So if anybody has one.
Hey, this is Kathy again, and I don't have a question. I really just wanted to thank Kim for not only coming to talk to us, but also for your experience and your knowledge, and you're always very honest about what you know, what you don't know, what you can do, and what you can't do. And I very much appreciate that. I'm sure the rest of the committee does too. So thank you very much.
Thank you, Kathy. I appreciate it.
Yeah, we greatly appreciate your work, and we're always kind of watching the state budget and, of course, this big tax reform package that's being talked about right now, to make sure that it leaves funding intact. Because, I really believe that while the tax climate, which is getting so much attention right now, doesn't really do anything to help our economic development, I also think that our workforce and having so many unhealthy people in our midst and, having people that are on Medicaid and, at the lower socioeconomic levels that, we need to keep this system intact to get our people where they need to be. And our educational systems need to be functioning on all cylinders to get people where they need to be to participate. So we really appreciate your work in this area. And, we just want you to know that we understand how important it is and the heart that so many of you guys work over there at LDH, with and trying to get our population healthy. So, and the amount of work that it takes with all those shrimp po' boys and stuff. So.
Well, thank y'all for having me. I greatly appreciate it.
Yeah, we do too. Thank you so much. All right. Well, you have a wonderful day, and thanks everyone for tuning in. And and
I'll give y'all this information, this follow-up information, and send it.
Perfect. All right. Well, let's keep in touch. Thanks a lot.
Thank y'all.
Thank
Bye.
you.
Bye.